Hello, my name is Roger Henderson and I'm a GP and I co-host the GPnotebook study groups. Welcome again to this GPnotebook podcast where we discuss bite-sized topics aimed at all those working in primary care. Now you can find us on all major podcast platforms, so do follow us to receive notifications about new episodes, and if you like what you hear, do please consider leaving a review to help other listeners find us. It really does help. Now in this episode, I'm going to be discussing abdominal aortic aneurysms, and this is a topic that's been requested by one of our listeners. Many thanks for this great suggestion. So, an aneurysm is essentially a permanent, irreversible dilatation of a blood vessel by at least 50% of its normal expected diameter. Abdominal aortic aneurysms, AAAs, or as I'll be calling them to keep it simple, AAAs, represent a critical and potentially life-threatening vascular condition which is characterised by the abnormal dilation of the abdominal segment of the aorta that should normally have a diameter of around 2 centimetres, although this can increase with age. An abdominal aneurysm is usually defined as having an aortic diameter of 3 centimetres or greater, with most of these arising from below the level of the renal arteries. The pathophysiology of AAAs involves complex interactions between genetic predispositions, hemodynamic forces, and degenerative changes in the vascular wall. Now, the aorta, being the largest artery in the body, is obviously subject to continuous mechanical stress from pulsatile blood flow, and over time this stress can lead to weakening of the medial layer of the arterial wall. Now, this is characterised by elastin fragmentation, collagen degradation, and smooth muscle apoptosis, with these changes often being worsened by chronic inflammation, oxidative stress, and proteolytic activity. This degradation of the extracellular matrix, particularly the loss of structural proteins such as elastin and collagen, then leads to the progressive aortic dilation seen in an aneurysm here. Genetic factors play a significant role in the susceptibility to AAA development, and familial clustering of cases has been observed, and this suggests a heritable component. One twin registry study found that the twin of a monozygotic twin with a AAA had a risk of a AAA approximately 70 times greater than that of a twin of a monozygotic twin without a AAA. Moreover, AAAs share common risk factors with atherosclerosis, although the two conditions have distinct pathological mechanisms. The presence of atherosclerotic plaques can contribute to aneurysm formation, though, by inducing local inflammation and weakening the arterial wall. Now, epidemiologically, AAAs are more prevalent in men over the age of 65, and actually rupture rarely occurs under the age of 60, but smoking is the most significant modifiable risk factor here. Smokers have a substantially higher risk of developing a AAA compared to non-smokers, and the risk remains elevated even years after smoking cessation occurs, but smoking cessation still remains vital in the management of a AAA. Smoking is also independently associated with histological high-grade tissue inflammation, and the duration of smoking is also significantly associated with an increased risk in a linear dose-response relationship. So keeping it simple here, each year of smoking increases the relative risk of a AAA by 4%. Other contributing factors include hypertension, and patients taking blood pressure lowering medication do have a small reduction in the risk of a AAA rupture. Hyperlipidemia, lipoproteins are elevated in patients with AAAs, independent of cardiovascular risk factors and the extent of any atherosclerosis, and a family history of aneurysms. So current data from the UK screening programme, which enrolls men at the age of 65, shows AAAs to be more common in white British and in particular white Irish men than in black or Asian men. This prevalence is probably falling and is around 6 times lower in women, although the rate of an aneurysm rupture is actually significantly higher in them. If we look at autopsy studies, the frequency of these aneurysms varies from 0.5% to 3%, but these studies may underrepresent the incidence of a AAA, as ultrasound studies do suggest a prevalence of over 4% in men and 2% in women. Now, as we all know as GPs, one of the key problems with AAAs is that they are often asymptomatic, and we frequently discover them incidentally during imaging studies that are conducted for unrelated reasons. When symptoms do occur, they typically include a pulsatile abdominal mass, abdominal pain, and in the case of impending rupture, severe pain accompanied by hypotension and signs of shock. One of the things I've learned in my career here is that severe lumbar pain of recent onset may indicate an impending rupture and should always be considered along with the other possible diagnoses. Now, there's a textbook classic triad of a AAA rupture, and this comprises abdominal pain, hypotension, and a pulsatile abdominal mass, although this presentation is not always complete. And we should remember that abdominal palpation has a low sensitivity for detecting a AAA, with detection rates being affected by aortic diameter, the experience of the examining doctor, and patient body size. Another good tip here is that physical examination should also include an assessment for other associated aneurysms, with the most common being an iliac artery aneurysm. Peripheral aneurysms are also associated with about 5% of patients, with popliteal artery aneurysms being the most common. Now, all this means that the diagnosis of AAAs relies heavily on imaging, and ultrasound is the preferred initial screening tool here due to its non-invasive nature, widespread availability, and high sensitivity and specificity. It's particularly effective in detecting AAAs larger than 3 centimeters in diameter. And although NICE recommends bedside aortic ultrasound as first-line imaging, a really key point here is that we must never delay a diagnosis and management of a ruptured AAA whilst waiting for the results of any imaging. CT angiography is the recommended definitive imaging modality for AAA rupture, since this provides detailed anatomical information and is also helpful with pre-operative planning. And it should also be considered for the definitive diagnosis of a ruptured AAA if a normal-sized aorta is viewed on ultrasound in the presence of severe hypotension. More rarely, MRI scans may be done, especially in patients with contraindications to a CT scan. Now, if you look at screening programs, these have been implemented in several countries, targeting men aged 65 and older, with evidence supporting their efficacy in reducing AAA-related mortality through early detection and elective surgical repair of large aneurysms. Current guidelines recommend one-time screening for men in this age group, particularly those with a history of smoking. Now, here in the UK, any woman or man under the age of 65 who think they are at higher risk, such as having a family history of the condition, do have the possibility of having a scan outside the screening programme. Now, UK guidelines state that 1. If no aneurysm is found and the aorta is less than 3 centimeters wide, then no further screening or monitoring is required. 2. With a small AAA, where the aorta measures 3 to 4.4 centimeters, no treatment is required apart from stopping smoking and following a healthy lifestyle, but the patient should have a follow-up scan every year. 3. A medium AAA, which has a measurement of 4.5 to 5.4 centimeter across. Again, no treatment is required apart from a healthy lifestyle, but follow-up scans are then repeated every 3 months rather than every 12. And 4. A large AAA, where the aorta measures 5.5 centimeters or more. In these cases, referral to a vascular surgeon within 2 weeks should occur in order to discuss treatment options, as most people with a AAA are advised to have surgery. So, following on from that, for larger aneurysms or for those demonstrating rapid growth, elective surgical repair is indicated, and urgent surgical repair is absolutely indicated for any patient with a AAA that's ruptured or is symptomatic. Elective surgical repair should be considered for an asymptomatic AAA that measures more than 5.5 centimeters or more than 4 centimeters but is growing by more than 1 centimeter in 1 year. I think it's probably worth mentioning here too that in some countries repair may be considered for women if their AAA measures 5 centimeters or more. The two primary surgical options here are open surgical repair, OSR, and endovascular aneurysm repair, EVAR. OSR involves direct surgical exposure of the aorta and the placement of a synthetic graft, whereas EVAR is a minimally invasive procedure that involves the insertion of a stent graft via the femoral arteries to exclude the aneurysm sac from the circulation. Now, EVAR provides greater benefit than open surgical repair for a ruptured infrarenal AAA in most patients, particularly for men over the age of 70 and in women of any age, and it also has a lower perioperative morbidity and shorter recovery times compared to an OSR. But open surgical repair may provide a better risk-benefit balance for men under the age of 70. So the decision between an OSR and an EVAR does depend on various factors, including the patient's anatomical suitability, any existing comorbidities, life expectancy, and personal preferences. Ruptured AAAs do represent a surgical emergency with a high mortality rate, even with prompt intervention, as unfortunately, even once an abdominal aortic aneurysm has ruptured and in the presence of medical care, the prognosis is grim. Over half of patients die before they even get to hospital, and those who do survive, unfortunately, have a very high morbidity. Predictors of mortality here include preoperative cardiac arrest, being over the age of 80, being female, if there's massive blood loss, and ongoing transfusion. So immediate resuscitation and rapid transport to a surgical facility are critical, with the choice of repair often depending on the availability of resources and the hemodynamic stability of the patient. Now, whilst EVAR is increasingly being used in the emergency setting, particularly in centres with appropriate expertise and equipment, OSR does remain the standard approach in many hospitals. Patients undergoing EVAR require lifelong imaging surveillance to detect endoleaks, graft migration, and any aneurysm sac changes. But in contrast, patients who undergo an OSR typically require less intensive follow-up, but may still be at risk for complications such as graft infection, anastomotic aneurysms, and incisional hernias. In contrast to patients with a ruptured aneurysm, the prognosis following elective repair of a AAA is good to excellent, with an estimated 70% of patients surviving for 5 years after repair. However, this prognosis is influenced by the presence of comorbid conditions, the strict adherence to medical therapy, and lifestyle modifications. The natural history of untreated AAAs involves progressive enlargement and an increasing risk of rupture over time, which is directly correlated with aneurysm size. So aneurysms smaller than 4 centimeters have a very low annual risk of rupture, whilst those larger than 5 centimeters carry a substantially higher risk, justifying surgical intervention in appropriate patients. So, that's a quick overview of abdominal aortic aneurysms, and I do hope you found the podcast helpful. But have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you'd consider following the podcast and leaving us a review on your favourite podcast platform. Feel free to get in touch via social media at GPnotebook or email us support@GPnotebook.com if you have any questions, comments or ideas for future podcasts. You can also visit us at GPnotebook.com to register for our virtual GP Notebook study groups, which occur all year round, and to download free shortcuts to help improve the lives of our patients in primary care. But until the next time, as always, thank you for listening and goodbye.